So we're doing a CABG, also known as a coronary artery bypass graft. The patient had a blockage in their left anterior descending artery. So with that, we had to grab the saphenous vein, or you could do the left mammary artery. That would just be replaced for the coronary artery, or the left descending. And
Okay, I'm ready for a soft count. Okay.
laps.
1, 2, 3, 4, 5.
Ratex. Oh. The marker is out there.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
The cottonoids.
0.
Needles.
1, 2, 3, 4.
Blades.
1, 2, 3.
Hypos.
1, 2, 3, 4.
And then bogey.
And my bogey tip. 1.
Alright. Can you move the ring stand so I can step behind there?
Yeah.
To right on there, please. Thank you. Alright. I'm gonna just 10 right tags. Through. Alright.
Oh, and Sandy, I'm sorry I did not see these needles over here. So can we do a recount on the needles?
Yes.
I have 1, 2, 3, 4, 5, 6 needles.
6 needles. Alright.
Okay, and then I can do my counts on this.
Yes.
So I've got perforating towel clip 1, 2, 3, 4, non-perforating 1, 2, 3, 4, mosquito 1, 2, 3, 4, curved Kelly 1, 2, 3, 4, 5, 6, straight Kelly 1, 2, Coker 1, 2, 3, 4, Alice 1, 2, 3, 4, Babcock 1, 2, tonsil 1, 2, right angle 1, 2, scissors 1, 2, 3, 4, needle holders 1, 2, 3, 4, sponge sticks 1, 2, and then I have 1, 2, 3, 4 double-ended Richardsons, 1, 2 Army Navy, 1, 2 rakes, 1, 2 malleables, and 2 Sens retractor, and a wheat lantern.
Okay.
And then for pickups, I have a Bickle Ferris Smith, Adson with teeth 1, 2, tissue forceps with teeth. Ooh. DeBakey 1, 2, Russian 1. I think that's another tissue forceps. So 1, 2, 3, 4, 5, 6, 7, 8.
Alright.
And then pool 2-piece section and 1, 2 number 3 knife handles.
Okay, and then you also have your yank bar section.
Yes.
Alright. Counts are done.
Thank you, ma'am.
Are you ready for medication?
Yes. NaCl. Okay.
Okay.
I will write that down.
Alright, we have NaCl, expires January of 25.
NaCl expires January of 25.
Oh, I see. Okay, so
Alright. And then we have xylocaine with epinephrine 1%, expires 4 of 19.
So I have xylocaine with epi 1%, expires 4 of 19.
Okay.
you really can't do it with a
So my role in this surgery today is being the surgical technologist, and our job is to always maintain the sterile field and to properly set up a Mayo stand with what the doctor is going to need. So first we have the marker, the local, and then he's going to make the incision, and you just kind of want to be ready for the surgeon with no matter what he needs. And then you want to have your fluid set, all your sutures ready, and additional tools that you need. These are going to go on my Mayo stand in just a second, but these are just additional instruments that he may need, and I don't want to clog up my Mayo stand and have them over there just in case he doesn't need them. So, we have the sternal saw.
What's this sternal saw do?
This is going to open up the chest cavity.
What do we use?
Media sternotomy.
Outstanding.
Thank you. And then we've got the Finochetto retractor, which is going to hold the chest open so that we can easily access everything we need to in there.
I'm anesthesia. My name is Katerina. I put the patient under general anesthesia with fentanyl and propofol, and then I use the paralytic so that they can stay still during the surgery. We'll use an endotracheal tube to administer and to help support the patient's breathing. And then we'll use medical tape to close their eyelids to protect their eyes and to make sure they stay closed during the surgery. Okay, so before I prep, I have to put on gloves so that way I'm not touching the patient unsterilely. This is an open glove technique.
And why are we doing it?
And we're doing this so that way we don't, I'm not touching the patient unsterilely whenever I'm prepping.
You're going to be prepping the patient, huh?
Yes. Oh, wow. Can you edit this part?
Just go.
Okay. Okay.
I only have so much memory on my phone. Put some music behind this. Then you know. What about like this going? Okay. Yeah, you name the video you want, but house is on fire.
Okay. We use it on the patient, and whenever you're applying it, you're going to do it in a counterclockwise motion from the point of the incision outwards. And in this part, you're going to go from the clavicle down to the pelvic region. And we're going to have to do two separate preps. So it's going to be one right here and then one on the leg for the saphenous vein. So whenever you're doing it, it's going to be going around in a big circular motion all the way down. And then you're always going to want to have blue towels on the side so that way you prevent pulling under the patient's body so that way there's no burns or anything. And then from here, you're going to hold the patient's leg because, like I said, you have to prep for the saphenous vein because they're also going to do an incision right here. And you're going to go around and you're just going to keep on going up all the way until you get to the ankle. Or would it be the foot?
Just the whole foot, really.
Okay, well, yeah. And just keep on going all the way around. And I would continue holding the foot until the surgical tech comes and they drape the patient all the way around.
Hello, doctor.
Yeah. How's any better after you?
Wait.
You're not getting out of this anesthesia.
Cat.
How's your day going, doctor?
Oh, it's alright.
Oh, I'm sorry, doctor.
That's alright. There we go.
Finalize my divorce.
As I walk through the valley of the shadow of death, I take a look at my life and realize there's nothing left.
The alimony's not as bad as I thought it was going to be.
Did you get to keep the cat?
I got to keep the cat, yeah.
Alright, let's do this.
Alright.
this. Yep.
Okay.
So we'll pull down this way first. And we're going to let this out, and we're just going to drop that. Okay. And then we're going to do towels first.
I know this is not your normal hospital. We apologize.
That's all right.
So it's a video.
Anesthesia, are you okay?
And
I got you.
We forgot to put the patient to sleep. Anesthesia, can you make sure you do that? Then you're going to grab Alex's and come around the other side. Okay.
I use my back arm for this.
How does it feel to stand there like that?
I feel like it would have been better if it was my left arm.
Can you imagine it would be a 300-pound leg?
All right.
You can do this with share.
Okay.
Will be.
Before we start, I'm going to after that I'll talk to anesthesia because
Me over there.
Sandy, I'm going to hand this off to you. Okay. And that whole me opening the drape would be cool if we can just totally forget that whole thing ever happened.
in hindsight, make sure we do a project we have supplies for. Nice.
You want it real one?
Look at that short one. Anesthesia, did you take my mic?
Yeah, do you need it?
You have it? Okay, no worries.
I'm not wearing one.
Anesthesia, do you need coffee or anything?
No, pretty awake right now.
Okay, just making sure.
I listen to podcasts.
All right, so the first thing I'm going to do is I'm going to go ahead and just make a mark here for the medium sternotomy incision here. All right, and what do we got for?
Oh, I got xylitine with epi, 1%.
You know, we forgot to. I know.
It was at this moment that he knew. He
Would you like a timeout?
Oh,
Yeah,
yes,
time out.
yes.
So we'll edit that out and start over.
Timeout, please.
Okay, so we have Jim Bobby. The procedure we're performing on him today is a cabbage. There's no known allergies, and the virus is a 3.
Was he given any systemic antibiotics pre-op?
2 grams of cefazole.
Cool. Sounds good.
I agree.
All right, we're good all the way around. We're going to be doing a cabbage today on this gentleman.
Hold on 1 second. I'm going to cancel the surgery, doctor.
Yeah, I've got a tea time at like 4 o'clock. So if we could,
Yeah, I don't know where they are. Hold on.
we'll just roll without it.
Okay.
All right, cool. All right, so we're going to make a median sternotomy incision, but first I'd like to mark my area, my incision line rather. Oh,
And I got xylitine with epi, 1%.
okay. All right, the local's been given. And may I please have a number 11?
Number 11.
Thank you. We're just going to make the incision here. All right. Now that we're going to get that open, you have a sternal saw available?
I do.
All right. We're going to use the sternal saw to cut open the sternum. Thank you. Thank you so much. And then we're going to place the finiento retractor to basically spread the ribs open so that we have access to the thoracic cavity.
There you go.
Thank you. Well, you can pass with a D.
What are you doing?
We're going to place this here.
Caesar, aren't you supposed to be by your machine?
Yeah, I just want to go back.
You gotta check vitals and tell me all about it before we go to the end.
All right. So now that we've got that in place, I think we're going to make we locate the heart, and then I have to.
Can't miss it.
We're going to make an incision into the. He's got a block in the left anterior descending artery, so I'm going to need a number 11.
Number 11.
Oh, it moved. So we're going to make that incision there. And I'm also going to need a Cooley clamp, please. Thank you. So we've got the ascending aorta clamped. We'll stay there. Alright, so then, actually before we go, let's try to get that paper. Alright, so we're going to cannulate, and we're going to be using the CBP because we're going to use a cold potassium solution to basically stop the heart so that while we're doing the operation, I'm not trying to hit a moving target. Alright, so we've cannulated for that. That part is complete. Now what I'd like to do is harvest the saphenous vein from the left leg. So I'm going to go ahead and take it on number 11 blade, please.
Number 11.
Patience for that. There we go.
And I got the hepatitis saline.
Perfect. To keep the graft moist and viable, we're going to pull that out and we're going to place that in there. Alright, so we're gonna go ahead and start the infusion of the cold potassium. And then I'd like to have a Cooley clamp, please. This is where we're going with that.
Cooley clamp?
Thank you. And I'm just gonna clamp the ascending aorta here. We're gonna be working on the left anterior descending coronary artery. So I will take number 11. Thank you. Oh, you're good. And then we're just going to make an incision there. And then we're going to go ahead. And then pop scissors, please. So what we're doing is we're just extending that incision because that's where I'm going to start my first anastomosis of the saphenous vein there. So if I could, at this point, I think we are going to go ahead. We're going to pull out the saphenous vein. We're going to cut it to size at this point. So if you have curved mayos or anything, you can go ahead and maybe cut that down to maybe 4 inches. Thank you so much. And I'm going to anastomose one end of this here to that left anterior descending coronary artery. Do you have 7-Proline? 7-Proline suture. Kidding.
This is double arm.
Okay, thank you. And alright, so we're going to get one end of that in there. And then what we'd like to do is we'd like to infuse the saphenous vein to check it for leaks before I make the final connection. Alright, we're irrigating right now just to make sure there's no leaks with the first anastomosis. Alright, and that looks good. So now we're going to go ahead and number 11 blade, please. Thank you. You're good. It's okay. I'll just fire you tomorrow. That. So I'm going to go ahead and remove the clamp here, and then we're going to use a different clamp. It's the key clamp. Thank you. Alright, that's about as close as that's going to get. Okay. And then I'm going to need a number 11 blade. And there.
11.
And then I believe it's a 7-0. That's 6-0 Proline.
6 Proline.
Thank you.
This is double armed as well, doctor.
Perfect. Alright, so we've completed the anastomosis from the ascending aorta. So that is complete. Pull that off now. And then I believe at this time, so now at this time we can discontinue the CDP, and we have little paddles. We could start the heart back up for our car battery. And at this time, then we're gonna also remove the cannulas that we replaced prior to the procedure. And some complications that can happen from this are going to be blockages of the graft itself, other possible infection, stroke, and atrial or even ventricular arrhythmias can also be. We've completed the cabbage, and the patient's probably more than likely, hopefully, going to do okay. There are complications that come with this procedure, such as like hemorrhaging, arrhythmias, whether they're atrial or ventricular. Also, the graft itself could become blocked, and the patient could also possibly have a stroke. So what we're going to do is we're going to keep the patient intubated, and we'll take them into ICU, where they will stay for about a week or two, where we will monitor their cardiac condition. And as long as they are become stable, we can extubate and put them on a mask for oxygen. And at that time, we will just write for follow-ups, and we'll see how they do.